what do you say? I mean, it really is somebody who saved your life.
A doctor and professor dedicated to public service becomes the patient. Coming up, the procedure that unclogged his artery and changed his prognosis. Good morning. It is April 6th. I'm Jessica Lovell, and welcome to the Morning Medical Update. The man you're about to meet survived a heart attack, only to get more bad news in a matter of months. But as Alexis Del Cid shows us, a certain treatment option turned things around.
There is something they can do for total occlusive disease, and that needs to be common knowledge.
One of the best parts of interviewing Dr. Michael Kennedy, who practiced medicine for decades before becoming a professor here at KU Med, is when you ask a question, Dr. Kennedy makes sure you understand the answer.
How would you explain to someone like me without any medical degree, what did they do to fix your heart?
So you know me, the teacher, I want to draw a heart.
You can draw.
The heart has a big pumping chamber called the LV, and then the right ventricle.
But before we get to the solution he's so happy about, we need to go through one of the saddest moments of Dr. Kennedy's life.
It was kind of dismal, you know. It was a depressing appointment. I'm sorry, I don't mean to get emotional, but it was essentially kind of a downward progress, kind of get your affairs in order.
It was August of 2022, 18 months after Dr. Kennedy had survived a heart attack and triple bypass surgery, and he had gone back to the doctor. After a stress test and heart catheterization, doctors discovered something, and it wasn't good. A chronic total occlusion, also known as a CTO. Plaque had built up, causing a total blockage in his coronary artery. Dr. Kennedy and his wife were reeling. Having just retired from practicing medicine, he was ready for his next adventure, which included teaching medicine, spending time with his huge family, and traveling with his beloved wife.
My wife and I were high school sweethearts.
And now this? How could it end this way? A few days later, the phone rang. It was his doctor again, who had spoken to another doctor who happens to specialize in treating CTOs.
He reviewed your case and he thinks he can help. So I was, you know, the emotional roller coaster.
And that's how Dr. Michael Kennedy came to see the University of Kansas Health System cardiologist, Dr. Tony Spaedy. And Dr. Spaedy could not have been more reassuring and comforting.
It didn't take a minute to say, this is a no-brainer. So he did a balloon procedure. And so in order to do that, you have to be able to pass a wire through the blocked area.
An hour after the procedure,
I was ready to leave right then.
They made him stay the night, but Dr. Kennedy was a new person. And that next morning, he walked out of the hospital and into those next adventures he'd been dreaming of having.
And we're so glad to have Dr. Michael Kennedy joining us here in our studio this morning. Alongside him is Dr. Tony Spaedy, a cardiologist here at the health system with a subspecialty in cardiovascular disease and interventional cardiology. Gentlemen, good to see you both.
Thank you. Good morning.
I'd love to have you, and Dr. Kennedy loved that story. How are you feeling this morning?
Oh man, I just feel great.
Retirement treating you well?
Oh yeah. Yeah, I'm having the time of my life now.
I bet you are.
Yeah, we are. We're planning more travel and working on our house. We're actually doing the paint and remodel work on our house, which is heavy exertion, as you can imagine.
Yeah, but it's fun.
And having a great time.
And doing it well. But before you got to do that, you had to get healthy and well. And Dr. Spaedy, so kind of help us understand this CTO, a chronic total occlusion. People understand what a blocked artery is, but is that the same thing?
Yeah, I mean, so there's different degrees of blocked arteries. There are a lot of people that you hear about, they'll have a 90% blockage or an 80% blockage. A lot of us, when we're in our 50s and 60s and 70s, will get a little plaque just as part of living long enough and eating American food and our genetics and rampant diabetes and everything else. So a little blockage is pretty common. And then some people will come in with chest pain and have a more severe blockage, and occasionally someone will have a total blockage, 100% blockage. which is just a little different animal as far as how it is a little tougher to fix.
So how does that CTO happen? And you described what can lead up to it, eating
Yeah.
that food and just getting older.
Right.
How does this all come together?
It's usually a very slow process, and then at some point it gets bad enough, the flow stops and the artery closes completely, and some people have a heart attack. So when you hear of people having a big heart attack, a lot of times it's the artery shuts off 100% all of a sudden. But many people it'll shut off very slowly. The body will kind of grow some feeders or some collaterals, we call them. So one artery will grow some tiny vessels to the one that's getting severely blocked. And then once it occludes, they don't necessarily have a heart attack. They may just not, some people don't even know any different. They feel the same, and some people, short of breath or chest discomfort or no energy are very common. They just know they know they can't do what they used to do. So it varies.
And Dr. Kennedy, in your case, you had already had the heart attack, you had triple bypass surgery. After that surgery, what was your recovery like? How were you feeling?
Right after, I actually felt pretty good. I think I had, on the grand scale, a relatively short hospital course. I was discharged after 3.5 days, which is, thanks to the extraordinary care team here, right? And then I felt pretty good for several months. I was walking quite a bit, but it wasn't until probably 9 to 12 months later, that's when I noticed that I wasn't even able to keep up the level of walking that I'd been doing.
And that just happened slowly over time. You started to feel some changes, something wasn't right?
Yep. And where I really noticed a difference was in July of 22, I went on a vacation with the family to Cape Hatteras, and walking around on the beach was really difficult, and I was having pain not in my chest. So that's something that viewers need to know. This doesn't have to present as the chest pain. Mine was kind of between my shoulder blades, and being a doctor, it still took me a minute or two to put the symptoms together and was like, could this be related to my heart? And so that's when I got back with my cardiologist, Dr. Owens. And
yeah, those signs, symptoms, they can be tricky.
Yeah.
Dr. Spaedy, let's talk about this procedure to remove the CTO. We have an image of Dr. Kennedy's artery before the procedure. Dr. Spaedy, what are we seeing here? Kind of help us understand what this is.
So perfect. Yeah, it's a little bit hard to maybe understand just looking at it like this, but it's all of us tend to have 3 main arteries to our heart. There's the one that goes down the front, we call it the LAD, and then there's one that goes kind of to the back side, and then another one, the right coronary artery. So this is Dr. Kennedy's left coronary artery, his left anterior descending. The 2 little arrows at the top are the beginning of the artery, where he's got severe plaque up there, and then the little arrow at the bottom is where it's 100% occluded. And there used to be a bypass that went beyond that, but as I recall, the bypass subsequently closed, and so that's why he was having all of the symptoms. But that's the vessel. So he did have some late filling or some collaterals, but it was very, just very faint. You could barely see the late filling.
What's the name of this procedure? Does it have an official name?
Well, basically it's still an interventional procedure like a stent, or you hear people talk about an angioplasty or a stent. It's still that, but the lingo we use a lot now is chronic total occlusion. So a CTO is the abbreviation. Chronic total occlusion just means chronic means it's been there at least 3 months, and we usually base that on symptoms and the whole picture. Sometimes we really don't know how long it's been there, and total means it's 100%.
So if we go back to that photo, what are you doing when you go in to fix the CTO? What are you doing in the plumbing?
Yeah, so we usually go in, and most people when we do this, we have to put in 2 catheters, one from the groin frequently and one from the arm. And we can get at it from both directions that way. If we need to go down a little, one vessel to get to another one, we can do that now. But we're basically threading a little catheter and wire right down the vessel. And the reason this was not very common, say 15 years ago, is we just didn't have the equipment. But now there's been some major advances that allow us to get the majority of these open safely. So we thread it down there. We usually use a tiny wire to get through the blockage. And then we balloon it. Sometimes, you know, we'll have to laser it or rotoblader it, or there's various things, but usually something to get it open. And then put a stent in to keep it open.
And can it come back? Is this something you have to keep watching for?
It can come back, and that was a big problem early on. It's become much less of a problem for several reasons. We know good ways now to keep it open, you know, to give you more of a prolonged benefit. One is almost all the stents we use now have a medication on the stent, so that lowers the chance that the stent will re-narrow pretty dramatically. So the rates now are, you know, close to single digit for most blockages, as far as, you know, under 10% for re-narrowing, even longer term sometimes. And then the other thing we do is we really try to optimize the size by looking inside the artery with an ultrasound. We get the exact size. We know really how big to make our stent, how to make it as optimal as we can. Those things have really changed the game on this kind of blockage.
So Dr. Kennedy, a doctor yourself, was this procedure on your radar?
Oh, no. So, you know, placing stents has been something that's been done for years, right? And but I knew from all my medical education that if you reach 100%, getting that wire is the trick. Getting a wire across the blocked area is the issue. And then there was some risk about expanding some of those because early on they had trouble with arteries rupturing.
That's right.
And then you suddenly have an emergent surgery that you have to attend. So this wasn't something that was on the radar. In fact, when I had the heart attack, they did a cath and they considered the possibilities, and they considered placing a stent and said, after their consideration, that it wasn't an option.
Were you awake during this procedure?
Yeah, yeah. So I have this weird thing where I'm actually allergic to the medicines that they use for sedation. And so they don't do total anesthesia for this thing. They usually do heavy sedatives. And so I tend to sleep for days with that. Wow. And so,
nice.
Yeah.
Another one.
Well, you would think, right?
Right.
But yeah, I was awake for the whole thing. They gave me just a little tiny bit of some narcotic, but and I tried to be quiet as much as I could and not disturb the team. I wanted them to concentrate on what they were doing.
I was going to ask you, what's it like having a doctor as a patient?
You know, it depends on the individual. So
sure
just
does.
like the patients, but generally it's been great. Their questions, you know, obviously they have better insights when we explain the risks, when we explain the procedure. We're able to use maybe the lingo we're a little more comfortable with, and I think that's nice. And I think he's more fully informed. I mean, we try to fully inform everyone, but it's hard to really explain, hey, here's the risk, here's how we do it, things like this. So you have a much better understanding of that. So I think that's nice. Yeah.
Some good benefits to that. So we have some before and after photos we want to pull up. The after is on the right. And is that correct? We can see the blood flow is back. Dr. Kennedy, could you feel the difference after the procedure right away? What's it feel like?
I don't know that I necessarily felt, you know, like some burst of energy. But I did, you know, even right after the procedure, I just, you know, did feel better. I don't know how to explain it. It you know, of course, there's probably some psychological part of that, right? But I had this real desire to get up and walk, and so with permission, I was able to walk in the recovery area where I was. Usually, patients kind of stay in bed, and but my wife and I walked laps, and then I had to really do some fast talking, but I also asked if I could walk out of the hospital instead of wheelchair out of the hospital.
And you did it?
They let me do it.
Yeah, you bring up the psychological. There's something to know that Dr. Spady's gone in, done his job, and now you're better. You're just all better.
Yeah. And then immediately, I knew my cardiac rehab, and I knew what I needed to do. So I just started working on that again. Obviously you have the desire to go crazy, right? But I took it easy and gradually built my steps up on a treadmill, and then we started walking outdoors. And
I was going to say, you got your high school sweetheart by your side. She's probably keeping you in line. She's been kind of your partner through this.
Yeah.
Talk to us about her and your family. And by the way, how old are we here?
Oh my goodness. God, I sent that picture in.
I love it.
We were 17, yeah. We were 15 when we first started dating, and then our parents had to drive us on our first date because we didn't have a license.
Love it.
But yeah, she's been my, she is disgustingly healthy and in every way, and but she has been my cheerleader the whole way through this, and such a positive attitude, right? And so that's a huge part of it, is when you have that kind of support and positive attitude, I think it goes a long way to good recovery. And so she's
a keeper?
She's a keeper.
She's a keeper.
47 years.
I think so. And Dr. Spaedy, that must make you feel good to know you sent a patient home and you know that the good support team is waiting to kind of carry the torch.
It is important, though, because some people don't have somebody to go home to, or somebody to support them, or even to drive them home, or it's kind of sometimes an issue. But it makes a big difference if you got somebody that's willing to especially get out and do things with you, keep you active, keeps you motivated.
So there's this idea of doctors being servants to their patients, and you've used your medical expertise to help others. Dr. Kennedy, a couple of photos from after the Joplin tornado. Gosh, I remember that. I lived there years ago. That was rough. What did you do down there to help out folks?
So I had an acquaintance at Heart to Heart International. The founder, Gary Morrish, is a family doc. And actually, his daughter attended our family medicine residency here at KU, and I was faculty at that time. And so, but just knew of him, and I had a break in my schedule. The timing was perfect, and so I called Heart to Heart and said, I can go now. And they're like, well, just wait a minute. We got to get a badge for you, or the National Guard won't let you through. But I went down, got the proper credentialing, and then went immediately. So I was actually there on day 2. Day 1, the roads weren't navigable, right? So, but day 2, and we went to the center of the destruction, and Heart to Heart set up a response trailer in the Walgreens parking lot. And so we treated the walking wounded, right? Because there were still some people, even after 24 hours, there were still people who had, lacerations and punctures and fractures and kind of more minor injuries, but didn't know where to go. Because one of the main hospitals in Joplin had also been hit.
It was flattened, or darn near
knocked
St.
off its
John's,
foundation.
You've also been to Guatemala.
Yeah.
What'd you do there?
That was actually also extraordinary. Went initially with Dr. Doug Gerard, who's now chancellor, and he went to do ENT surgeries, and I heard about it, asked him if I could go do primary care, and so we went and saw, the first time is 2004, and saw almost 600 patients in 4 days. People were lined up. That people had walked
to see you.
To 50 miles to come see us. So it was a pretty extraordinary. But the big deal was we took students, and so that turned into a recurring. And we changed it from a medical mission to an international education experience, because we didn't want to go be the great saviors who came down to Guatemala to save people. We wanted to help the local healthcare community and to teach our students to be respectful and ethical.
And you're also helping really close to home, because you help with our rural healthcare needs in the state of Kansas, something that matters to our Kansas families. Why is it so important for you to make sure you're doing that outreach?
Well, the state of Kansas actually funded my medical education. And then I, in turn, served 4 years to pay that off. But I loved it. And so I was in a town of Burlington, Kansas, a town of 2,800, and I was there for almost 10 years. And that's, after that is when the calling to come teach overpowered my desire to be there. But our kids had grown up and moved out. So I really had a fondness in my heart for rural medicine and realized the major issues of access to care in rural areas. And I thought, they need competent, broadly trained family doctors to help in rural communities. And we're talking small rural. The town I was in was 2,800. But, a specialist, unfortunately, there's just not enough to keep them busy in a town of 1,000 people, but a family doc can go there and make a huge difference in terms of access to care. So when I came back to KU, that was my mission, was to increase educational opportunities, increase workforce, and improve access to care in rural areas.
Well, thank you for your service across the board when it comes to health care. Be sure to get your questions sent in to us. Use the chat on YouTube, Facebook. You can tweet us or email us at the Medical News Network. That info is all right there on your screen. Let's get a quick check on our COVID count. Dr. Dana Hawkinson joining us on this Friday. Good morning. How are you?
Hi, good morning.
Hi.
Doing good. Yeah, the COVID count looks pretty good right now. I think probably myself and Dr. Stites need to be away from the health system, and I think that's doing some good things. Because we have 30 total, but just 15 active, which is really good. But again, unfortunately, a high proportion of severe disease with 5 in the ICU and 2 on the ventilator as well.
Dr. Hawkinson, you spotted a headline out of the New York City area. The New York State Department of Health has once again found poliovirus in the wastewater. Now, last summer, a county outside of New York City had America's first polio case in nearly a decade. We thought this virus was pretty much eradicated, but now doctors like you are tracking it in these reports in the wastewater. Any possibility of an outbreak? What do these singular cases tell us?
Yeah, so there is, poliomyelitis, which is the neurological disease, which causes the paralysis. That's what we want to protect everybody against. Dr. Kennedy knows all about this as well. And then there is the surveillance for wastewater. And it necessarily shouldn't be a surprise that we are finding it, given the amount of travel and people coming from other countries and the overall lack of full vaccination. I think what people should understand, though, is the fact that it is very easy to protect ourselves against this, protect our families and our communities, and that's with having those high vaccination rates. We here in the United States use the injection or the inactivated poliovirus. That provides protection against poliomyelitis disease. But we know that in some counties and some communities, there are very low rates of vaccine coverage. So I think the main message for this is continue to be active in your prevention, continue to be up to date with your vaccines. This does include polio vaccine, and this will provide protection from disease. So I don't think, number one, we should be too surprised that we are finding it in wastewater. But number two, the main point is that we can all be protected if we increase, number one, our community rates of vaccination against polio, but also individual in our household to keep everybody healthy and well.
Dr. Hawkinson, thank you so much. Let's check and see if we have any reporter questions on today. Let's get to our community questions. Okay, Juan asks, what are the symptoms of CTO? Dr. Spaedy, are they all over the board, or can we focus in on something?
I'd say that the most classic, so there's classic symptoms and there's atypical symptoms, which Dr. Kennedy had some atypical symptoms. And then there's people that are completely asymptomatic. And usually when we're fixing this, we're going after the symptoms. So we're not, there are many of these we'll leave alone. Just fixing one artery or one blockage doesn't make you live longer. It's more to improve the quality of life. So the key classic symptoms are chest discomfort and shortness of breath. But there's a lot of other things, including you are more likely, there's multiple studies, you're more likely to be depressed if you've got a lot of blockage that can't be fixed, or you're more likely to have no energy or low exercise tolerance, or some people, like you said, their pain is in their back, between their scapula maybe, or maybe it's just in their jaw or just in their neck. So it can vary a little bit, but the classic ones are chest pain, trouble breathing, fatigue.
Which would be all the signs to get some help and to start asking questions immediately.
Yeah, at least, right. Ask some questions, see, try to sort it out a little bit.
All right, so Angela had a question, Dr. Hawkinson, for you yesterday, and I wanted to sneak this in here. Can you speak about what she was calling a new COVID vaccine?
Okay, yeah, don't necessarily understand the question, but I think we can answer it in two ways. Number one, there was recent news that the FDA will probably announce in the next coming weeks for people to get an updated booster, bivalent booster, but right now the bivalent booster is still the same one that was in the fall. But this new updated recommendation looks like it will be for those people that are 65 and over or have other immune compromising conditions and are at least 4 months out from their last booster or last vaccine dose. Otherwise, as far as new vaccines go, we know there was a recent published study looking at an intranasal vaccine, and that looked to be very good for immunogenicity, so helping with the immune system, blocking infection, and very safe. But again, this was an early study done in hamsters, so it's in the very early stages. And hopefully those two answers answered her question. Number one, about the possibility of certain populations being advised to maybe get a new updated booster, but also a full new vaccine that is being worked on at this point in time as well.
Dr. Hawkinson, thank you. Angela, I hope that answered your question that you sent into us yesterday. Let's get to today's takeaway here on this Friday. Dr. Spaedy, what do you want folks to take away today?
Well, I think probably still the key is prevention to a lot of this. So eat healthy, exercise, get your weight where it's supposed to be, watch the blood pressure, read, Google the Essential 8. That's the American Heart Association's 8 things we all should do to live as long as and healthy as life as possible. And then if you keep having trouble, ask more questions. See if you can't, if you have known problems and it sounds like there's nothing they can do. Things have changed in the last decade, and there are a lot of things that each year it gets a little better. So there might be something available now that wasn't available in the past if you're still having trouble.
For sure. Don't go way past Google.
Go way past Google. That's right.
Dr. Kennedy, as a doctor and a patient, what do you want our takeaway to be today?
Well, I just have to reinforce the things that Dr. Spaedy said. And because I have the classic, diseases where if you neglect yourself, right, and don't exercise and don't eat properly, then I was overweight, diabetes, high blood pressure, cholesterol, and now heart disease. And so it's the classic thing. And my family history was also pretty bad. But listen to your body. If things just don't feel right, you don't have to have the answer. You don't have to seek the answer on Google. You can see your healthcare provider.
Yay.
And really get their expert advice, right?
Yeah.
And start with your primary team and work your way up from there. And I think, because if you live out in a remote area, then you're not going to have access immediately to the excellent cardiology team here at KU. But you do have access readily through your doc who can make referrals for that.
Absolutely.
And so that's my advice, is to listen to your body. If things aren't feeling right, then you may not know what's wrong, but there's others that can help with that.
But you know something isn't right.
Yeah,
so
that's exactly
keep pushing
right.
forward. Great advice. Dr. Hawkinson, what's your final advice for the week? Wrap us up.
Yeah, that is just really echoing what Dr. Kennedy said. It is continuing to ask questions and seek those answers. We have excellent physicians like Dr. Spaedy and medical teams here to help give you those accurate answers and treat you and get you better. And would also just like to thank Dr. Kennedy for all his work here at the health system in the state of Kansas, and as we heard, abroad as well. So thank you very much.
Hawk, thanks so much. And thanks to all of our guests today and our viewers. Make it a terrific weekend. We'll see you back here Monday at 8. Coming up Monday on the Morning Medical Update, what we eat and drink eventually gets filtered through our liver. So how clean do you think your filter is? I'm Jessica Lovell on the next Morning Medical Update. What you need to do to avoid permanent liver damage, Monday at 8.
Subscribe to our Morning Medical Update and Open Mics with Dr. Stites podcasts. Now, everywhere podcasts are available.